So the last little bit we need to cover for the exam is the knee. So when we talk about the knee anatomy, one of the big differences between the elbow and the knee are the bones involved. Remember, we saw in the elbow that all three bones, the humerus, the radius, and the ulna, all three of those were involved in the knee joint. The same is, in the elbow joint. The same is not true in the knee, right? We have this bone that comes down, that is the femur, with that big, huge block shape. Put that on that side, and cheat and put that on that side. Those two big condyles, the medial and the lateral condyle that come down for the femur, and then they have that nice convex surface to them. And then we have that nice concave surface of the tibial condyles that come up, that intercondylar eminence, and then it comes down this way. So notice in this case, the knee joint is just formed by the medial condyle of the femur, the medial condyle of the tibia, the lateral condyle of the femur, and the lateral condyle of the tibia. Notice, and this illustration shows it nicely, the fibula articulates up here underneath the lateral condyle of the tibia. So it's not actually a part of the knee, right? It's not a part of the knee joint. So it's just the tibia and the fibula, which again, give more strength, more structure, more weight bearing in its anatomy. So knee joint, medial and lateral condyles of the fibula, of the tibia with the medial and lateral condyles of the femur, end of story. However, as you can also see from this illustration, there are a lot of accessory structures that help to facilitate this as well. And so these are things that we are responsible for identifying on a model or a real knee or an illustration like this. So we want to make sure that we are able to identify them. Now, if you looked at the pictures from the textbook, you can see there are a lot of them, and you see them here as well. However, you're only responsible for the stuff that is on your list. And part of the things that are on that list are 5 ligaments. Remind me again what a ligament does.
Bone to bone.
Connects bone to bone. Excellent. So let's talk about identifying those. Starting first with the most prominent of the ligaments, and that is this one out here. This one out here, notice, goes from the patella to the tibial tuberosity. This ligament is what is known as the patellar ligament. Now notice it is a part of, and this picture is a little inaccurate in this here. This doesn't actually attach to the bone up here. Up here, what we actually have is the patella tendon.
That was going to be my question, is does the patella tendon attach superiorly to, and it attaches to the sartorius and all of the quadriceps?
Bingo, it's the quadriceps. The patella tendon is the tendon of the quadricep muscles. The quadriceps femoris, right?
Right.
That is the rectus femoris, the vastus medialis, vastus lateralis, vastus intermedius. Those 4 muscles all come into a single tendon that attaches to the patella, and then that patella ligament goes from the patella to the tibial tuberosity. So all the muscles of the quadricep actually insert into the tibial tuberosity, and they do it through this tendon. But because this tendon has a sesamoid bone in it, technically this part here is considered the patella ligament.
Well, yeah, bone to bone and versus bone to muscle.
Exactly. So yeah, they simplified this picture a little bit, and I think the next picture shows it a little better. well, no, it does it as well. So again, those just have to, because it's got to go to someplace. So they've attached it to the bone, but that's just so that, you know, it's an artistic thing to anchor it there.
So this ligament goes from the patella to the tibial tuberosity.
Tibial tuberosity, absolutely. So if we were to draw it on our illustration here, basically it would come down the front of the knee joint like this and attach to that tibial tuberosity.
So just for clarification, if you have Osgood Schlatters, are you familiar with that?
No, I'm afraid I'm not.
Okay, that's okay then.
Okay.
It's a I'm pretty sure it's where the patellar tuberosity or the you have an over prominent tuberosity during development, and there's several other things that go around with it.
Okay, so I'm sorry, I'm afraid I'm not familiar with that condition. But what I would say is that obviously the patella, like all sesamoid bones, job is to help to modify the angle of the tendon so that it is more efficient in its function. And if you have enlargements of these bony attachments, that absolutely could impair the function of the leg.
That's, yeah, absolutely.
All right, so that is an external ligament that we can see here, but there are two other external ligaments, and they come from the outside. One of them attaches to the medial epicondyle. Just wanted to go back to this, change the color. From the medial epicondyle of the femur down underneath the medial condyle of the tibia. This one is to the side, and as such, it is known as the collateral ligament.
Is it collateral because it's literally co-lateral?
Well, collateral means to the side, right? You hear about it on the news all the time, right? Trump's out there saying, yay, we just bombed this chemical, weapons making plant in Iraq or something along those lines. Sure, that school bus worth of kids were killed as well, but that's just collateral damage. That's okay. We got our target. So collateral means to the side. Now, notice there are two sides to this, so we do want to distinguish it. And this one is not on the fibula side, so it is called the medial collateral ligament. Or because it attaches the femur to the tibia, it is often referred to as the tibial collateral ligament as well. So both of those would be acceptable names for that structure. We can either call it the medial collateral or the tibial collateral ligament on that side. And not surprisingly, we have the exact same thing on the other side as well. And obviously I've pronounced these medial and lateral epicondyles just for my point. But from the lateral epicondyle coming down onto the head and neck of the fibula, which we also see here on our model, is a second collateral ligament. This one's on the outside of the knee or on the fibular side. So not surprisingly, this would be the lateral or fibular collateral ligament. So here we have three ligaments that are outside of the joint cavity to help to support the knee and stabilize the knee in place. All right. Questions on that?
So the third ligament, which is the which comes from the lateral epicondyle of femur.
Yep. Down onto the head and neck of the fibula.
Fibula, right?
I'm sorry?
The head of fibula.
Yeah, head and neck of the fibula, correct. All right, so questions on those three? Put this one over here for that. Move this over here so it's conveniently out of my way. All right, so those are the three that are outside the joint cavity. But as we can see kind of from this illustration, and I have a couple other pictures I will show you as well, there are additional ligaments inside the joint cavity. So let's take a look at a lateral view of the leg. Here is the femur, and as we've noticed, the condyles of the femur kind of come back in this knuckle-like appearance. And then we have that concave surface of the medial and lateral condyles of the tibia. And we'll go ahead and put the tibial tuberosity out here so we can tell what's anterior and what's posterior. And if you notice, inside of the knee, there are two ligaments, and these ligaments cross. One attaches to the front of the tibia and attaches to the back of the femur, while the other one attaches to the back of the tibia and attaches to the front of the femur. We have these two crossing ligaments, and what is the fancy name we give to these crossing ligaments? I know you know.
Cruciate?
Cruciate.
Cruciate, excellent. Whoops. They're the cruciate ligaments. And of course, what do we call the two cruciate ligaments?
Anterior or posterior?
Yeah, so one is the anterior cruciate ligament, and the other is the posterior. Of course, in sports, it's a lot more fun when they just abbreviate it. So you get to hear that Billy, that running back you got in the first round, tore his ACL, right? It's much more cool when they say ACL, but that's what they're talking about, the anterior cruciate ligament. And there's also the posterior cruciate ligament. However, we have two problems. The first is that these ligaments both connect in the front and both connect in the back. So how do we know which one is anterior and which one is posterior?
From their origin?
True, but how do we know where they originate? You're actually absolutely correct, but how do we know where they originate?
Where you can view it from in that orientation?
Not a bad guess, although as it turns out, when we look at it from the back and we look at it from the front, we can actually see both. Notice, and here we'll do it here. This one is the green one from our view here, and then this one back here is the orange one that we see there. So we see them crossing there, but there's an even simpler way. So one is a little bit more forward, one is a little bit more back. But if you remember, there is a raised bump between the condyles of our tibia. What was that raised bump called again?
The intercondyle eminence?
Intercondylar eminence. Notice one of them connects and attaches to the front of the intercondylar eminence, and one of them connects to the back of the intercondylar eminence. And it's their relation with the intercondylar eminence that determines what they are. So in this case, the green one is indeed the anterior cruciate ligament, and the orange one is the posterior cruciate ligament. So it's by their relationship to that intercondylar eminence where they get their name. So now the second issue we have is, what the heck do these cruciate ligaments do? Well, remember, their goal is to help to stabilize the leg, and or specifically the knee. So notice I've got my knee in an extended illustration here, but if I flexed my flexed knee would look a little something like this, where again, we have the condyle of the femur sitting in our tibia, and now it's flexed. So we brought it down this way, whereas if it's extended, we would bring it up this way. Now, if you think about it, when we flexed the knee, if you think about the way the two tendons are located. Notice in this case, our green tendon, the two ends would actually be brought closer together. So is there going to be a lot of tension in the anterior cruciate ligament when the knee is flexed?
No.
No, but notice our posterior cruciate ligament is extended much more out. So it is the posterior cruciate ligament that helps to stabilize the leg, stabilize the knee, when flexed. So notice if you're running, for instance, there is a tremendous amount of force and acceleration putting on the knee in that direction. And our posterior cruciate is what is going to stabilize it in that location. However, when you extend the knee, as you extend the knee, that is when you, whoops, hold on, increase the tension on the anterior cruciate ligament. And if you try to extend it too far and hyperextend it, that anterior cruciate ligament's going to stop it. So the goal of our anterior cruciate ligament is to stop or prohibit hyperextension of the knee. And so, of course, then when that running back gets hit in the front and his knee is hyperextended, that's when he tears his anterior cruciate ligament. And again, one of the things that you're seeing now is that our athletes are becoming so big, so strong, so fast, so huge. You now have these, 275-pound linebackers who are running a 4.6 40. Right? Just from a physics standpoint, that is way too much mass moving way too quickly. So more and more you are seeing athletes who are tearing their ACLs in non-contact injuries, just planting their foot and trying to change their direction. The momentum of their motion is enough to cause the hyperextension of that knee and tear their anterior cruciate ligament. So in basketball and football, you are seeing more and more examples as our athletes are getting bigger and stronger. We're seeing more and more examples of non-contact tears of that anterior cruciate ligament, just because of the force and mass they get going at such an accelerated speed. All right. Questions on that? Excellent. So those are the 5 ligaments that you're responsible for. 2 inside the knee, 3 outside the knee. Let's take a look at some different views. Here is a nice simple model. Notice we're looking at a posterior view of the knee. So notice here we see the posterior cruciate ligament starting in the back and working its way forward. And we can actually see a little bit of the anterior cruciate as it is sticking out. But notice the other thing that we can see is the medial collateral and lateral collateral ligaments. Not only is the lateral collateral and the medial collateral medial, but the medial collateral is a much more broad, much more wider ligament. Whereas if we flip to the other side, notice the lateral collateral is much more narrow, much more band-like. So not only is one medial and one lateral, but we can also see that it is typically smaller on the lateral side and bigger on the medial side. Notice this also does a great job of showing us attaching that ligament to that that lateral epicondyle of the lateral condyle of the femur. The other thing that this particular picture shows really nicely for us is it shows us our cartilage. Notice here in blue, we have the hyaline cartilage, that articular cartilage that we know has got to cover the condyles for the joint of the knee. And we see a little bit of the hyaline cartilage peeking up from the lateral condyle of the tibia as well. But notice the other thing we see are these big chunks of orange in here. These 2 big chunks of orange that we see here are the menisci. Remember, the menisces are fibrocartilage. that is found in this joint, providing extra support and extra cushion. Notice they basically surround the condyles of the femur, anchoring them more in place. And of course, this ring of fibrocartilage on the tibia side, pardon me, on the fibular side, is the lateral meniscus. And so, of course, this one on this side over here would be the medial meniscus. And lastly, notice in here as well, we can see our cruciate ligaments. Again, notice here, that is our anterior cruciate, and this is our posterior cruciate. So we can see those crossing ligaments in there as well. And I think that's everything on your list. Did I get everything?
Articular cartilage is on there.
So remember, the articular cartilage is the blue hyaline cartilage that is on the surfaces of the medial and lateral condyles.
So any of it, not any, they don't have specific names.
No, again, remember, like we said, all synovial joints are going to have articular cartilage. That's the hyaline cartilage that helps to form the joint, whereas the meniscus are fibrocartilage. So again, that's one of the reasons we want to distinguish them, is because they're made of different types of cartilage. The menisci are made of fibrocartilage, while the articular cartilage is made of hyaline cartilage. Excellent. All right. Any other questions on that?
Just because I'm curious, do you know how meniscuses are torn?
Great question. So there are a couple things that can happen. So let's actually cheat. That is an excellent question. Let's actually cheat and go back to this picture.
I mean, because we talked a little bit about how, you know, the ACL, the PCL is torn.
Yep.
Meniscus tears are pretty serious.
They are, because they're cartilage, and as we know, cartilage heals very slowly, very poorly. In fact, when you typically tear the meniscus, what they're more likely to do is go in and just try to shave off and remove part of it, try to smooth the surface as much as possible to maintain the pocket. So, because otherwise the knee will actually lock up on you and not move smoothly, or will actually decouple as a result of that. That's actually why I had my third knee surgery, was I had to have 20% of my meniscus removed.
Okay.
But,
Yeah.
what you see here, notice on the medial side, remember we talked about on the medial side, this medial collateral ligament is very broad, very wide. And
Yes.
because it's broad and wide, it actually connects to the medial meniscus. So often when the knee is hyperextended and the medial collateral ligament is strained or damaged, it will actually pull on the meniscus, and commonly the medial meniscus will be damaged when the medial collateral ligament is damaged as well.
Okay. I've heard of that.
Yep. But the other thing that we talked about, as I mentioned, again, damage to the knee, injury to less synovial fluid can cause irregular surfaces or pocketing to appear in the hyaline cartilage, or even damage to the bone. And as that bone damages, or as you have arthritis, which starts to, pocket away at that as the bone weakens and softens, then it's more likely to catch and tear the ligament as well that way. So the meniscus as well that way. So it can be that as well.
That's how I did mine. I have what are called bucket handle tears. It's on the rear of the meniscus, like literally all the way on the back, and the PCL.
And that's because you have arthritis in your knee? Is that what's causing it?
I was a power lifter and I squatted 881 pounds.
Wowzers. So yeah, so that's a tremendous amount of stress to put on this. And again, that fibrocartilage helps with compression. But yeah, when you're flexing the knee and dealing with that type of weight, it can be potentially damaging for those. Absolutely.
Yeah, I've torn my pec tendon, and my right triceps, and a bunch of other stuff.
Wowzers.
Yeah. So, but I'm not doing that anymore. So
I'm glad to hear that.
yeah.
Again, I'm not going to discourage anyone not to be, to work out and be healthy. But yeah, when you start getting damaged that much by it, then you do have to be careful. Absolutely. All right. Any other questions on the knee?
How did you hurt your knees? Or how did your knees blow out?
I originally hurt my knee the first time playing football in high school. My senior year in high school, I tore my my ACL and my lateral collateral ligament. Did some other scar damage. Had some minor surgery, enough basically to patch it up so I could finish the year. And then yeah, because I was young and stupid, and, and finished the year. And then a couple years later, doing karate, I was throwing a round kick, and basically all the scar tissue that had built up in there tore. And then, like I said, actually a couple years ago, then I had to have my meniscus partially removed. So, yeah.
Orthoscopic surgery is not what it was to, you know, then versus today.
Yeah, no, when I originally tore my ACL, my surgery was 6.5 hours. I have two.
Oh my goodness.
Well, because it wasn't just the ACL. I did a lot of collateral damage as well. And again, that was my senior year in high school, which was 1873. And so back then, it was, you know, leeches and things along those lines. But no, they didn't have the orthoscopic. So I have two, I don't know, 8-inch scars, one on the front and one below my knee, and one on the lateral side where they had to go in and reconstruct it. In fact, the week I had my knee surgery, my mom's best friend had a kidney transplant, and her surgery was only 4 hours. So she had 4 hours to get a new kidney, and they spent 6.5 on my knee. So,
that's crazy. I tore my labrum, my shoulder labrum, and it was like a 2-hour surgery. And the doctor's like, "This is stronger than it ever was before you tore it."
Yeah, no, the technology is great. I mean, when I had my meniscus removed, it was 2 tiny little insertions where they were able to go in there and do it. So yeah, it's the technology has improved greatly.
Sir, let's come to the point, like if we are going to ask in the exam for the knee joint.
Yes.
So we're going to point all these ligaments to find or identify the ligaments, or
yeah, absolutely. So can I show you a picture of that knee joint, like on like we just did? Can we have this on the exam, and can I have an arrow that points here, and can I say identify this structure? Or I can move it, identify that structure, or I can move it, identify that structure, and so on and so forth, or that structure? Absolutely. Those are exactly the types of questions that could be asked. Or on the exam, could I, you know, ask what, you know, about, you know, what the ACL does or what the PCL does or something along those lines? Absolutely. All testable material. My knee surgeries aren't testable material, but all the rest of that stuff was testable material. All right. So that is all of the content that I wanted to cover. But as I mentioned, I did want to promise to have the opportunity to offer a question and answer review. So if there's any questions or anything else that you're not clear about, I'm happy to answer those questions now. So please, by all means, feel free to ask any questions. Remember, if you don't ask questions, I assume you've all mastered the material and I make the tests harder.
Professor,
Yes.
I have a question.
I have an answer.
Will you go over again about like the structure of the long bone, of how you would ask on the exam of like where the articular cartilage is for see at like the proximal and distal epiphyses?
Mm-hmm. So let's do this. These are the pictures. So we can do this here. So pick any random long bone. Which long bone did I pick?
The humerus.
Excellent. Is it right or left?
I think it's left.
Left. Everybody agree? Well, so let's think. I know, because I'm always looking for bone features, I know that the big knob is the medial epicondyle. And what direction does the medial epicondyle point?
Medially.
Medially. And I know this is the lesser tubercle. And which way does the lesser tubercle point? Anteriorly. So if this is anterior and this is medial, is this a right or a left humerus?
Right.
Right. Anterior, medial. The only way that works in my arm is if it's in the right arm. All right, excellent. So, but that wasn't the question you asked. So,
Sir,
yes,
can we ask like questions about the answer review for the 30-point skeleton from
no,
those?
nope. Because again,
No?
graded for content. So I'm not going to give you the answers to those. If there's a question you're confused about, I'm happy to help you to decipher the question to make sure it makes sense. But the goal isn't to give you the answers of those. The goal is for you to figure those out. But let's answer this question first, and then I'll happily help you if you're confused by anything. So again, I drew an artificial one when we did it the first time, one of those dino bones. But again, we know the basic anatomy is that diaphysis. So we have the shaft, which is the diaphysis. We have the two epiphyses, which are the heads. And thankfully, because we recognize this bone, we can tell them apart. Is this one here the proximal or the distal epiphysis?
Proximal.
Proximal, excellent. And this one would be the distal. So we have that. We know that the outer surface would have a periosteum on the outside of it. And if we cut it on the inside, we know there would be a hollow space in the center. And what would that hollow space in the center be?
Medullary cavity.
Medullary cavity, excellent. And we know there is this transition region. What is this transition region known as?
Proximal metaphysis.
Right, the metaphyses, that neck region, absolutely. And within there, there's either going to be a chunk of hyaline cartilage or there is going to be a thin line of compact bone, right? If it was a chunk of hyaline cartilage, it would be the epiphyseal plate. And if it was a thin piece of compact bone, it would be the
Epiphyseal line.
Line.
yeah, epiphyseal line, excellent. And then we know the articulating surfaces are going to have some type of tissue on the surface of that. What would that tissue be?
Hyaline
Articular
cartilage.
Hyaline
Hyaline
cartilage.
cartilage.
And what would we call it based on its location?
Articular
Articular.
cartilage.
Articular cartilage, excellent. So yeah, I can show you a dino bone that has been cross-sectioned and ask the question there, but we can also answer all of those long bone anatomy stuff on a real bone as well. So absolutely, those are things that we could identify that way.
Okay, thank you.
Laura, I totally understand the statement. What I would say is that I think that's more of an issue of the format of what we're doing this. Like I said, when you actually have the opportunity to hold the bones in your hand, it is so much easier to get this stuff to click into place. The fact that we're not able to hold these bones in our hand, I think, is the real challenge to this part. I think when we're in the classroom, the tissues, because we're not used to looking at the microscope and we're not used to looking at the body from that point of view, is not very intuitive. And so I think that's the real challenge with it. Whereas, like I said, once you get to hold the bones in your hand, that familiarity really, really helps. The problem is you're not getting to hold those in your hand. And so that is one of the challenges of that. But that's also why you really have to take advantage of things like that practice anatomy lab, in that you can take a bone and rotate it and dissect it around. There's some great tools in there to help you to get some of that, at least virtual relationships of these things and be able to put the pieces in place. The other thing that I would point out and emphasize, and again, I do not want to discourage anyone from doing what they did, because everybody did an amazing job on their presentations, but also a lot of people presented a lot more information than we're really responsible for, right? We don't need to know what muscles attach to which individual bone features. We do need to know what blood vessels or nerves go through what bone features. The only bone feature you're responsible for the function of is a bone feature that forms an articulation. So on the exam, I could ask you to identify this bone feature. And what would that bone feature there be? What is it?
Radius.
Trochlea. Nope, it is the trochlea. That bone feature is the trochlea. So absolutely on the exam, I could have a big fat arrow pointing to this region right here, identify the bone and bone feature, and you would say the trochlea of the humerus. But also on the exam, I could ask you to identify the bone and bone feature that articulates with this bone feature. And what bone and bone feature articulates with the trochlea of the humerus?
Trochlear notch of the ulna.
Perfect. The trochlea notch of the ulna. So the only relationship you need to know with these bone features are the ones that are forming joints. The other functions I don't care about yet. When we get to the muscles, do you need to know that the deltoid tuberosity the deltoid muscle inserts into the deltoid tuberosity? Absolutely. But for this exam, you just need to know that this roughened up patch right here on the lateral aspect of the bone is the deltoid tuberosity. And the other thing that gets intimidating is when you look at some of these pictures in the atlas, you can see that every single bone has dozens of bone features. But what you have to remember is you are just responsible for the bone features on your list. So one of the things that I encourage you to do with your atlas, when you have that atlas, go through the atlas and just highlight the ones that you're responsible for. So that way, very quickly, when you're studying your atlas, you can quickly see, I can ignore these 3 things because I don't need to know it. I just need to know these 4 things on a bone. And that makes it a lot simpler, right? The hyoid has a ton of features, but how many are you responsible for on the exam? How many bone features of the hyoid are you responsible for? None. The vomer has a ton of bone features. How many are you responsible for on the exam?
And just the
None.
vomer.
Yeah, inferior nasal concha has a bunch of bone features. How many are you responsible for?
Nothing.
None. Right? So just focus on the material you're responsible for on the exam, and hopefully that will help it to be a little less overwhelming. Plus, remember, you have 5 whole days to study for this.
It's not only anatomy, there are more things.
Yep. True, there's all the physiology that you need to be responsible for as well. And you still have one more homework assignment to finish, but that homework assignment is going to help you to learn this. Now that we know all the bones and bone features, it should be easier to put the bones together and do that 30-point review, because that's really what that 30-point review is about. All right, Elena, did I answer your question? Excellent. So, Joed, is there a particular question that you were confused about on the 30-point review?
No, I just my question was like the composition of like the nasal septum, which parts are involved with to make this the nasal septum. Like
Okay.
I put 5 or 6 parts. Whether we are correct or not, what I'm saying is like whether we have put the right information or not. This was my question. Like these are the parts that make the nasal septum or not.
So what I would say is that one of the keys to that, and again, I haven't seen your answer, but what I would say, one of the keys to this is remember what we are doing here is talking about bones and bone features. So the nasal septum is a perfect example of things where there's cartilage, there's other fibrous tissues, there's membranes and stuff that are helping to form that dividing structure of the nasal cavity. And I don't care about any of those. All I care about are the bones and bone features that form them. Okay? So technically there are 4, but there's really only 2 on your list that you are responsible for. Of course, if you gave me all 4, I wouldn't mark it wrong. But technically there's only 2.
So technically there are 2. So we're not responsible for the cartilage, for the crest, and
yeah, cartilage, is that bone and bone features?
no.
No. So if it's not a bone or bone feature, then we don't care.
Okay, so just
Yeah, I just want the bony components of it.
thank you.
All right. Next question.
The widest point of the hips, would that be the iliac crest or there was a part of a spine? I'm trying to find the picture.
So again, so here's what I would say. Because again, remember, I'm not going to necessarily give you the answers to the questions, but what I will say is this. Hold on 1 second. All right, this is not the picture I wanted, but it'll serve our purpose. Here is a skeleton. What did you just ask me?
The widest point of the hips.
Okay, and what did you ask me if the correct answer was?
I'm sorry, I muted. The iliac crest.
Okay, so the iliac crest is here.
Yes.
Is that part of the hip?
Yes.
Really? Where's your hip joint?
Mm.
Now, I'm not talking about when you're salsa dancing and someone puts their hands on their hip. When I say hip, I mean what the hip joint is, the ball and socket joint. Is that anywhere close to the ball and socket joint?
No.
No, but that
So it
clarifies.
cannot be the widest part of your hips.
So down on the femur.
That seems like a more reasonable type of answer. Something maybe possibly down on the femur.
Yes.
Ashley, were you just dropping the mic on me when I did that one? Is that what that was? Boom, drop the mic. Okay, excellent.
It's more like dropping knowledge.
Oh, okay. All right, what's next?
Can you go over the telling left and right of the tibia and fibula again? I didn't quite follow your notch.
Sure. All right. So the tibia, again, even though the fibula is right there next to it, it just as easy, whether it's by itself or whether it's together with something. For the tibia, there's two things that you are, for any bone really, what you want to do is you want to orient the bone the way it would be in your body. And the best way to do that is by getting two basically points of orientation, 2 points of reference. Great question. Yes, if you have already submitted your skeletal review and want to make changes, you are welcome to make changes, and I will only grade the most recent version. So yes, if you've already submitted it, you are welcome to resubmit it. All right, so what we need to do is orient ourselves on the bone. And luckily, most bones have pretty distinct features that allow us to do this. For instance, this big bump right here. What is this big bump right here called?
Tibial tuberosity.
Tibial tuberosity. And which way does it project?
Anterior.
Anterior.
Anterior. Excellent. You are correct in that it's on the proximal end. We wouldn't want to use superior. You're right, it's on the proximal end, but it is projecting anterior, right? The tibia is the medial bone. So that means if this is over here, the fibula is over here, this must be the lateral side of the bone. However, if the fibula wasn't sitting next to it, at least we have this nice big large hook that sticks out. And what's that nice big large hook that sticks out?
Medial malleolus.
Medial malleolus. Excellent. So this is the medial malleolus. And which way must it project?
Medial.
Medially. So this has got to be medial. This has got to be anterior. And obviously we know this up here is superior. So with this being anterior and this being medial, there's only one way it could fit in my body. Would this bone orient the correct way if I put it in my left leg?
No.
No. So what must this bone be?
Right.
Yeah. And really, that's what the best way to do it with all these bones. Like I said, it's nicer when you can hold it in your hand because literally you can say, all right, this is how it's going to be in my body. And then you can try to figure out, would this be on the left or would this be on the right? You're just going to have to do that virtually now. Right. So again, looking at that, you can kind of figure it out. So usually by using multiple keys, multiple cues, you can figure out whether it's left or right. And you can do that for all the bones. However, there are some bones that have some nice dead giveaways, right? The two easiest bones, and they're only the easiest if you know what to look for. But as we talked about, the two easiest bones are the patella and the fibula. Remember, as we mentioned with the patella, we have these two facets, facet 1 and facet 2. And notice they're not the same size. One is bigger. And what do we know about the bigger facet? Or one could say the larger facet?
Right.
The larger facet is lateral. The larger facet is lateral. Okay, so we know this has to be lateral. So then it just comes to orient this the way it is in the body. This is a posterior view. All right, so we're looking at it from the back. This is the anterior view here. And remember, the base is towards the top and the apex is inferior. So right now, if you were standing up, this patella that I've got the square around is oriented exactly the way it would be in your body. All right, for it to be the one on the left, you'd have to be turned around facing this way. But for the one on the right, which is where we see the facets, that is oriented the exact same way it would be in our body. So if that right side needs to be lateral, can that be in my left leg?
No.
No, so it must be a right patella. Makes it super easy to identify. And the other one that is super easy is the fibula. I know when you look at the fibula, it is a bit intimidating, but it's kind of got this nice arrow shape. The head is more boxy, flat on top. Then we've got this long, narrow shaft. And then we kind of have this cool looking arrowhead at the top. Okay. Now, when we look at this arrowhead and this particular view of the arrowhead, when we can see that smooth surface for the talus. Notice if we go back to this picture, notice this picture, I really can't see that articulating surface for the talus. And so I'm not really able to see the notch very well. But when I look at this surface, this happens to be the medial surface, but it doesn't really matter what surface it is. As long as I can see that smooth surface for the talus, then that allows me to see the notch. Now, this end is superior and this end is inferior. So what I need to do is I need to rotate this bone the way it would be in my body. If I rotated this bone up, then now notice, oops, move that out of my way. My head would be located up here. Now, obviously it's off the field of view, but what we can see here, no, I totally understand. Like I said, that's why I'm recording this, because again, I know I've gone over on time with everybody, but I wanted to give people the opportunity to get this information if they wanted it. So with the lateral malleolus projecting down, and if I can see the articulating surface for the talus, which I can do here, and I can do here, then all I have to do is see which side the notch is on. In this one over here, which side is the notch on?
Left.
The left. So this is a left fibula. Here, the notch is on the right. So this is a right fibula. So notice when we stand it up, it's easy. It's a little trickier if I have to fit the whole bone onto the field of view. But like we said, at this point, you just have to tilt your head. So if you tilt your head, right, tilt it to the side, you can see that this notch is on this side. So this notch for this bone that's here solo by itself, is it a right or a left?
Right.
Excellent. And this one up here, what is it?
Left. Left.
Is it?
Right. This is
Right.
also
Yeah, notice they're both rights. So just that simply, that is how you tell the tibia and the fibula left and right. All right. Questions on that? All right, it is getting late, but I will take one more question if you guys have it. Brains are full? All right, well then what I will say is, as always, if you have any questions, please feel free to email me. And have a good weekend, study hard. Please turn in your review on time. Friday by 8 a.m., not 8:02, not 8:01, 8 a.m. As soon as you finish it, turn it in so you do not forget. That way you can sleep in on Friday. All right. Have a good weekend. Take care. And I will see you. Good luck on the exam. And I will see you Wednesday.
Thank you.
All right. Bye, everyone.